welcome to the November podcast episode of Radiology AI. My name is Dania Daye, and I'm the Associate Editor for Social Media for Radiology AI. And today, my co-host Paul Yee and I are very excited to bring a new episode of the Radiology AI podcast, where we'll be interviewing Dr. Eliot Siegel. Dr. Siegel is Professor and Vice Chair of Radiology at the University of Maryland School of Medicine and Chief of Radiology and Nuclear Medicine for the Veterans Affairs Maryland Healthcare System. He also has adjunct appointments as Professor of Bioengineering at the University of Maryland College Park and as Professor of Computer Science at the University of Maryland, Baltimore County. Dr. Siegel was on the IBM Jeopardy team as their medical consultant when they played Jennings and Rutter in the famous AI versus human Jeopardy match. Dr. Siegel has written over 300 articles and book chapters about PACS and digital imaging and has edited 6 books. He also started the world's first imaging informatics program and has been involved in the informatics fellowship program for the last 22 years. He has made more than 1,000 presentations throughout the world on a broad range of topics involving computer applications in imaging and medicine. Dr. Siegel is a fellow of the American College of Radiology and the Society of Imaging Informatics and Medicine SIM. Dr. Siegel, we are very excited to have you with us today. And without further ado, I'll turn it over to my co-host, Dr. Paul Yee, to start the conversation. Paul?
All right, Dania, thank you for the introduction. And thank you so much, Eliot, for joining us on the podcast.
Thanks, Dania. Thanks, Paul. Really appreciate it.
All right, so Eliot, you've been involved in imaging informatics for the past 30 plus years. And in doing so, you've been involved with developing and implementing the first iterations of a lot of the technologies we take for granted today, including PACS and DICOM. Can you tell us and our listeners a little bit more about your background and what got you into informatics in general, and perhaps more recently in AI and machine learning?
Sure. So I've always been interested in computers as long as I can remember, and even as a kid, was really into reading science fiction books. One of my favorites was by Robert Heinlein. It was called "The Moon is a Harsh Mistress," and it probably is still a good read today. And in that, there was a computer that ended up essentially evolving into consciousness and into intelligence. And they ended up having a fair amount of fun with it learning what humor was. And it explored the whole idea of computer consciousness and, computers evolving as time went on. The whole idea of, could a computer have superhuman intelligence? And if it did, couldn't it create a computer that was smarter than it was, the same way that we humans are able to do that? And could that be, a really interesting way that humans may end up evolving? And so ever since I was a really young kid, maybe 6, 7, 8 years old or so, I was really fascinated by that. So I ended up minoring in computer science in college. And I finished college early, in a little bit less than 3 years. And I got a job somehow in the Division of Computer Research and Technology at NIH, DCRT. And at that point, as kind of a high school kid, I got my first access to an IBM mainframe and ended up doing all sorts of really cool projects. I remember vividly that they were working at the time on ECG signal processing with what was then, referred to as the equivalent of AI. And also they were trying to colorize CT scans, thinking that if they only picked the right color, that they'd be able to, improve on the monochrome display that they had. That was a project that clearly didn't work out, but, it's really fun getting my introduction to imaging, in high school or college, working for those. This was actually the equivalent of sort of a year finishing college early, and then before I started medical school. And then I actually got a chance to work as a medical student in the VA's central office, as it ironically turned out. And I ended up getting access to some early machine learning to predict how many residents should be allocated in all specialties within the VA, and to try and figure out, what were the criteria and how to apply them using machine learning. I also worked my way through medical school doing programming of anesthesiology machines, as it ended up turning out. And I started my residency in radiology, actually being asked because of my computer background to create a computer schedule for radiology resident rotations and a schedule for the faculty on call. I ended up solving the resident rotation challenge using a funny way of doing machine learning by actually creating trillions of random schedules. And then the computer just picked out which ones were closest to the criteria. So certain residents didn't want to work with other residents or certain attendings. And there were all sorts of arcane rules that they threw at me that, didn't seem to be easily solved with a conventional program. And so ended up doing that. What I learned is the last thing in the world you want is to be a first-year radiology resident making your faculty's schedule. And so I, number one, learned some technical things with computer scheduling. Number two, I learned politically, if anyone asks you as a first-year resident to make faculty schedule, the definite answer is no thanks. But that's another story for another time. So always had that really strong interest. And as AI has sort of reemerged in popularity over recent years, it's been really fun to be able to re-engage my early interest in AI.
Thank you for sharing. That's really interesting to hear how you've really done a lot of, I say, first in imaging informatics, whether it's with scheduling, and as we'll learn a little bit more with some of your work in machine learning. But shifting gears slightly, you also started one of the first, if not the first, imaging informatics fellowship in the country, which has trained many present and past leaders in imaging informatics. Can you tell us a story of how that fellowship started and the changes it's gone through over the past couple of decades?
Yeah, so it's actually a great story. I really had not thought of creating an imaging informatics fellowship, and I got a call that seemed to me to be random from my first imaging informatics fellow, as it ended up turning out, Khan Siddiqui, who later went on to work for me and later went on to head up IBM healthcare imaging and some other healthcare things within IBM. He called me and it was lunchtime and I'm eating my lunch and I pick up the phone and Khan is on the phone and starting to talk about an imaging informatics fellowship. Well, it wasn't a scheduled call, it was kind of a cold call. And what I used to do during my lunch times is I used to play speed chess. And so I'm in the middle of a 3-minute game. You only have 3 minutes to make all your moves. I'm trying to think 4, 5, 6, 7 moves ahead. And I'm playing this game, and all of a sudden, this guy calls with a little bit of a Pakistani accent and talking with me about whether or not we have an imaging informatics fellowship. And so, using, I don't know, maybe 1/10 of my consciousness, ended up telling him no, we didn't have a imaging informatics fellowship, and giving him sort of one-word answers. And I'm sure it must have come across as being pretty rude, which is very much different from the way I interact with students and mentees, as you know. And so after the call, I think he was kind of puzzled that all he got were sort of these one-word answers, and ended up calling back. And when he called back, we had a really, really great conversation. And I was sort of inspired to create a fellowship where the main goal was to do cool, innovative, creative, interesting things. And that was his charge. And we together ended up crafting a fellowship that was more structured as time went on. But one of the main tenets was creativity and innovation. And another major tenet was being able to work with industry. And so to combine innovation and creativity and what had been done outside of radiology and essentially bring those technologies into radiology. And so, the whole idea about asking really interesting questions of the fellows, what represents image quality? How do we optimize workflow? What represents a quality report? How do we use machine learning for radiology decision support? What are cognitive challenges? How do you overload a human being with too much information? And how do you have a computer essentially offload some of that? And so as time has gone on, we've had many fellows. And what's been one of the most gratifying parts of my career has been how many of my fellows have gone on to essentially running their own fellowship programs or doing really cool things in leadership. Going to ACR or RSNA and looking at the imaging informatics committees, it's so gratifying to see so many of my fellows actually themselves in leadership positions and teaching other people. And so for me, that's been just incredible. And so that fellowship has evolved as time has gone on. Ken Wang, one of my former imaging informatics fellows, actually runs the fellowship, but I get a chance to play an adjunct role and continue to work with all of the fellows. And so it's been really wonderful.
Oh, thank you for that overview. And as an alumnus of the Imaging Informatics Fellowship myself, I'm really grateful to Khan Siddiqui calling you that day a couple decades ago.
I am as well.
But speaking of cool, innovative things, one of the things that you had done early in your career was back in the 1990s when PACS was coming onto the scene. And in many ways, PACS was a technology that's not so dissimilar from AI in that it was really something that at the time was potentially paradigm shifting for how radiologists work with and interpret imaging. Can you share with us a little bit about the story that led you to develop the first filmless radiology department in the world, along with any lessons you learned that might have parallels or be analogous to AI today?
Sure. Well, so just at a high level, one of the things that was really interesting was as we became the world's first filmless radiology kind of department and enterprise, I got a lot of feedback from colleagues pretty much around the country saying that it was going to be the end of radiology, that the idea that clinicians wouldn't physically come down to the radiology department anymore to look at images, the idea that sometimes ER physicians or ICU physicians would see the images prior to radiologists seeing them, ended up being perceived as sort of opening up Pandora's box and being the first stake in the heart of the end of radiology. And what it actually ended up doing was expanding, encouraging innovation and creativity in radiology, making images universally accessible. And this whole idea of being able to turn static images into a movie ended up creating the ability to have numerous MRI sequences and CT sequences. All the things that we take for granted today are all possible because we made that jump to digital. And even back then, we were thinking of AI, which really ended up evolving a lot more slowly than we'd anticipated. So when I was a third-year radiology resident, my then chairman at University of Maryland brought me to a conference in Boston, which was the RISC Consortium, looking at electronic medical records, specifically radiology information systems. And I'd never really thought about working in the VA per se, but the chairman had offered me as a if I would stay on in the department past my last year of training in radiology, the ability to run the department. And so I've had this really kind of topsy-turvy career where I started out as the head or chair of a department coming right out of my residency. And part of what I was promised by the VA and by University of Maryland was the ability to set up this department as a completely digital filmless department. And I told them, maybe stretching the truth a little bit, that they could either have the world's first filmless department or the world's last film-based department, and which would they want? And managed to get help from inside the VA, a pathologist, Ruth Dayhoff, who'd set up pathology digitally at Washington, and her colleague, Peter Kuzmak, and then got tremendous support from the VA. Traveled all around the country and talked to experts at the time, such as Ron Aronson and many others, who sort of told me, it's kind of early for PACS, give it another 10 years or so, but you really probably won't be able to open the department filmless and digital. But fortunately, I guess as a young kid who really didn't know any better right out of residency, I thought I could actually pull it off. And we ended up creating and opening a brand new hospital a few miles away from the original one without bringing any film boxes or light boxes or any of the other things we'd need for film. And so it was kind of like a kamikaze mission where we weren't able to really turn back. And so we ended up actually encouraging the vendors to do things they've never done, telling them that the hospital was completely dependent on it. And so when we first opened up, we had at least 2 or 3 visits every day. The morning would be Russia, the afternoon would be Australia, the next day would be the Netherlands, and so on, people looking to see what a filmless radiology department would look like. And even had a visit from the Pittsburgh contingent with a young Paul Chang there, who came by to sort of see what was possible and what worked and didn't. But we had all kinds of challenges that you might think are quaint or funny. The lawyers told us, well, we really couldn't stop making film because there was a legal requirement to keep film for 6 years, and they couldn't understand how we could meet that if we weren't making film. And of course, we told them, but we could print film anytime we wanted to or needed to. Monitors were lower resolution, and we didn't know whether that would be a detriment in comparison to higher resolution film. We thought people might look at images forever because they could window or level or zoom, and when would they ever stop? Although that sounds silly, that was a major concern. Life expectancy, when we first got the first CRT monitors, they only lasted about a month and a half or 2 months. Fortunately, we had them all under warranty. There was no such thing as an Ethernet network. It didn't exist when we first opened our PAC system. So we used a proprietary network that was developed for the military. And 1 terabyte of storage had to last us 6 years because it cost $800,000 for a single terabyte. So we had to use major league compression in order to actually be able to store even images that were created with sequences that had fewer images. So it's a fascinating story. And at the last minute, right before the government was about to purchase the system, we were about $1 million short, had to do a little horse trading of our angiography and other equipment and get that later on in order to actually pull it off. And we ended up finally doing that. And because we had the EMR integrated, we were able to go filmless before other systems such as the DoD or Hammersmith Hospital, who bought the system at the same time, but they weren't able to go completely filmless for a few years after that. So it was an amazing adventure.
It's an incredible story. And I think that there's a lot of parallels that we can draw to AI. Speaking of that, you've been involved with AI in addition to things like PACS through pretty much every iteration in the past couple of decades, including back in 2011 with IBM Watson, long before the current deep learning era. I'm curious, what's your take on the current state of AI in radiology and where the field needs to go to really make the most impact, both for our field and for our patients?
So for the most part, we've, in the past few years, demonstrated that we can reproduce what we'd already accomplished in the previous 30 years with what was referred to as computer-aided diagnosis or computer-aided detection. We're finding things such as lung nodules, intracranial hemorrhage, pediatric bone age, liver lesions, fractures, segmentation. They're all things we'd already done, but we demonstrated that instead of taking years to do them, we can do them in a matter of hours or days with folks who do not have that same level of subspecialty training in image segmentation and image analysis, et cetera. And so the question now is, where do we go now that we've demonstrated all that and that these AI programs can make findings, and what's impactful? Well, one of the things that we had documented early on in PACS was our ability to be able to do workflow studies. And we determined that radiologists spend 85% of their time when they're interpreting a study doing the reporting, calling the images up, waiting for hanging protocols, et cetera, and only spent about 15% of our time actually doing the image interpretation and recognition of findings. And the question is, can we improve that 15% to something closer to 70 or 80% and improve our efficiency by a factor of 6-fold to 10-fold, which I believe we can do. Other things that I want to do is communicate important findings. Not only do we communicate urgent or unexpected findings, but we follow up to make sure that someone followed up on our recommendations. That's not happening. And I think we can do that better with machine learning techniques. I want to make radiology reports more machine intelligible. And so we already have great schemes such as BI-RADS and LungRADS and PI-RADS that work well, but they are on a very specific categorization of findings focused on fairly narrow questions. We need to make our general reports in radiology more machine intelligible by taking free text and converting that into machine intelligible data. So, Paul, I think that in your report that you just gave, here are the 6 bullet items that I think you just said, agree or disagree, and hopefully you agree in the majority of cases. And so you can use a combination of structured and free text, but it all gets made to be machine intelligible. But we still have numerous limitations in our current implementations. For example, we don't look at trajectory of change. If I'm looking at lung nodules or lung masses, I look at the current study, but I don't do what a radiologist really does in real life, look at the previous study or the previous 3 studies or whatever. AI needs to start doing that for breast cancers, liver lesions, et cetera, because it'll be way more accurate looking at that trajectory of change. I think those things would make us much more accurate and much more analogous to what a radiologist really does with image interpretation.
Thank you for those insights. I think those are all really astute observations and future directions for the field. But in addition to these use cases, one of the things I've been thinking about is how to make AI impactful by translating these technologies into products that will be available for commercial use. Because as we've seen with things like PACS, these things really didn't catch on until they were widespread through working with vendors. So I'm curious, what's your opinion on the role of partnership and collaboration between radiologists and industry for developing AI for our field?
Yeah, so as you know, anybody who's looked at my conflict of interest statement can see dozens of different companies and entities that I've worked with. And I'm a huge believer in the importance of translating our research papers and grants into actual clinical practice. I think having radiologists that are creative and innovative and think out of that proverbial box, working with these companies is absolutely essential to making sure that what's developed is clinically relevant and useful. And what works theoretically and in actual practice are really pretty distinct. So one of the most fun things for me in my career, and one of the things I have the most fun doing with my imaging informatics fellows, is by constantly trying to predict and anticipate the future and working with these vendors. It makes it really fun, and it's possible to make these predictions be self-fulfilling. When you're the goofball or idiot that they bring out and ask the question about where do you think things are going in the future, when you make these predictions, it actually, when people listen to them, actually does become self-fulfilling because they end up doing what you think the future says it might do, kind of like the Terminator series, I guess, in some way. And so it's been really fun thinking of predicting the future and also thinking of playing some tiny role in the direction that things go in the future. One of my favorite projects right now is actually taking a relatively lower end CT scanner, say an 80 channel CT scanner that we may buy for $300,000 in comparison to a $400,000 DR system, for example, and actually look at, without doing the scanogram, scanning a chest or an abdomen at about the same dose or half the dose as a plain film X-ray. And the whole question of, could we then, with a less expensive scanner using a lesser dose, create, using the CT scanner, the equivalent of a chest PA and lateral or an abdominal radiograph, and then with the underlying CT images that have actually been created at these doses, could we use AI to be able to make finding lung nodules and fractures and adenopathy and all sorts of things, so that we have a new paradigm where you look at a chest PA and lateral, looks to you like that it's been reconstructed from the CT, but an AI program underlies that and looks for multiple different pathologies that it informs as plain film. And so now you've got this new paradigm where you actually are spending less money, lower dose, similar productivity, and you've got the ability to significantly improve sensitivity and specificity, going from 22 to 25% sensitivity for lung nodules in the range of 5 to 10 millimeters to 98, 99%. With this is just one of a number of huge examples, and working closely with industry to figure out how to do that and how to be productive, and what new paradigms we need to invent, how we need to reinvent billing. Do I want to bill every one of these patients as a CT or as plain film studies? And we don't have paradigms. The ACR recommendation and guidelines suggest we shouldn't be doing CTs for these routine chest PN laterals, and yet we have a technology that can do that much less expensively. So this whole idea of new ways to work with industry and new ways to think out of the box and reinvent the way radiology is practiced is what makes the practice of radiology so uniquely fun for me, and I hope for all of the people that I end up working with.
I totally agree. I think the future is incredibly bright and exciting.
Yeah.
So, in light of that, just as a closing question, what are you most excited about for in the next decade, either in radiology AI or informatics or anything else in general?
Yeah, so I'm most excited about lots of things. So let me see if I can give you a quick answer on that. Right now, I'm most excited about AI for image reconstruction, PET scans with 1/10 or even 1/100th of the time required to do the image acquisition, major reductions in dose, um, and the potential to be able to rethink if we can do PET at doses that are similar to chest radiographs, would we use PET in different ways, for example? Or the same goes for CT with dose reduction without loss of texture, as we see with iterative reconstruction. And MR, the ability to rethink MR sequences. I'm excited about the FDA rules changing so that AI can actually learn like a fellow or a resident learns real time from a radiologist rather than coming shrink wrapped and not changing. The FDA has suggested that it will allow submissions that let systems learn constantly. I'm excited about AIs acting as radiology scribes to increase our efficiency from that 15 to maybe 80%. I'm excited about new rapid development with transfer learning so that when diseases such as COVID emerge, we can do transfer learning with pneumonias and ground glass algorithms and lung nodule algorithms, and rapidly create a new algorithm within a matter of days, for example. Workflow optimization. I'm excited about platforms that may allow me to pick best of breed applications. I don't want to just listen to, if I hear my favorite song on the radio or when I'm out somewhere, I don't want to have to download an entire CD of songs. I want to just download that one. In the same way I can do that now, I want to be able to do the same thing with my favorite applications. So a platform that lets me mix and match AI applications, a platform that allows me to take multiple programs that do the same thing, like finding lung nodules or work in concert with each other and create ensembles of algorithm is really exciting. I think the idea of moving from algorithms that make findings like lung nodules or intracranial hemorrhage to clinical applications like a trauma package or a multiple sclerosis package, an emphysema package are really exciting. And I think taking into account prior probabilities, the likelihood that a Hispanic patient is going to develop cancer in the next 6 years is 1/6 of the likelihood of a Pacific Islander developing it. And if you know about your patient, you can make a priori predictions that should be figured into the AI estimate of how it's doing its image interpretation. And finally, I think that quality assessment. Is my scan a good scan? Should my CT be repeated? How can I create the best scan? If grandpa had a really bad scan or really bad contrast timing 6 months ago, how can I fix that in the next scan? And how can I use what I've learned to improve quality as much as possible? So I'm super excited. There are so many things for us all to do together. And so I'm thrilled at the opportunity to be on the podcast to share some of those. And I hope some of these discussions may inspire folks such as yourselves to continue to explore so many of these amazing questions and continue to pose them yourselves. So thanks so much for the opportunity, Paul and Dania.
Eliot, thank you for spending time with us, giving us all of these insights, all of these interesting stories. And I think all of our listeners will find this really inspiring. So again, thank you for joining us. And I'll give it back to Dania.
Thank you, Paul and Eliot, for such a great discussion. And especially thank you, Eliot, for sharing with us your journey in informatics and AI. and really your vision of how AI is going to change and improve how we practice in the future. To our listeners, thank you for tuning in to the November podcast episode. And don't forget to rate, review, and subscribe to our Radiology AI podcast series on any of iTunes, Google Podcasts, or Spotify. Stay tuned for our next episode.